Hi, everyone. Welcome to the first ANID webinar of 2021. It's hard to believe it's been 6 weeks or 6 months already since our last webinar, but we're delighted to be back to share with you a really incredible webinar today on how to be anti-diet. This webinar is in partnership with Reasons Eating Disorder Center, and we'll be hearing from two wonderful presenters who I'll tell you more about in just a minute. First, want to give a special shout out to Reasons Eating Disorder Center for being our webinar sponsor today. Please check out their website or give them a call if you have any questions about their center. And some housekeeping items for today. There should be a chat box and a question box. You're welcome to use either throughout to record your questions throughout the time that the presenters are talking. They do plan to present for about 75 minutes, and then the final 15 minutes will be for a moderated Q&A session, which I'll lead based on the questions that come through in the chat box throughout. So we'll also be posting the webinar recording. You'll get that recording later today, and then we actually are not doing our post-webinar small group discussion today, unless people want to stick around. The presenters have graciously offered to stay after the webinar for a few minutes to have some informal discussion. If you would like, we can facilitate that if people would like to talk with the presenters. This afternoon, you'll receive the recording from ANID. Tomorrow, you'll receive an email from Oakton University with a webinar evaluation. You must complete that within 2 days to receive your CE certificate. And then you'll receive your certificate within a couple weeks. So if you have any questions about any of this, feel free to type it in the chat or type it in the questions throughout, and we'll be monitoring that throughout the webinar. All right, I do want to go ahead and introduce our presenters. Claire St. John brings compassion, and Claire, if you want to say hello or just wave or something. There's Claire. Claire brings compassion and understanding to her nutritional counseling practice. She is passionate about repairing broken relationships with food. She holds a master's of public health nutrition from Loma Linda University, and after completing her rotations at Eisenhower Medical Center, became a registered dietitian. Her method of practice includes exposure and response therapy, motivational interviewing, and compassionate understanding paired with firm encouragement. Helping people reconnect with food and normalize their eating patterns is the most rewarding part of working with eating disordered patients for Claire. Encouraging people to be able to make peace with food, enjoy meals with loved ones, and move through the world without fear is why Claire chose the field of eating disorders. She enjoys learning about her clients' passions, what they're reading, what they're studying in school, and what their hobbies are, taking a whole person approach to treatment. Claire enjoys reading, writing, hiking, and cooking. And Fiona LaRosa is an experienced behavioral health marketing professional who is a community relations specialist and the director of business development for Reasons Eating Disorder Center. She has been working in the eating disorders field since 2011 and has held positions as professional outreach representative for eating disorder and substance use since 2011. Use facilities, a counselor and a treatment center for adult women with eating disorders, and providing outpatient case management and treatment placement services for clients struggling with addictions and eating disorders. She's passionate about helping people locate resources to support treatment and recovery, advancing education about eating disorders and addiction, and connecting with the mental health community. Fiona holds a Bachelor of Science in Human Services and enjoys traveling, public speaking, cooking, and hiking with her dogs. All right, Fiona and Claire, I'm going to stop my screen share and you all can start yours and I'll let you take it away. Thank you so much for being here.
Thanks, Lynn. We're really excited.
Struggling. Hang on, everybody. I apologize. Let me try this one more time, actually. This should work. Share screen. Boom. Okay, we're ready.
We're ready to go. Thanks, everyone. Thanks, Lynn. We're really excited about this. Always really enjoy working with your organization and so thrilled with what you do. So thank you. I'm Fiona. This is Claire, and we're going to talk today about how to be anti-diet. We're going to cover a bunch of different topics, and we're going to try and really frame this as a presentation that gives you a lot of takeaways, a lot of how-tos. So we hope that's your experience, and please share questions in the chat box. A little bit briefly about Reasons, who we are. We're a gender inclusive program in the Los Angeles, California area. So we do treat people ages 12 and older, although our adolescent programming is currently paused. So for the time being, because of COVID, we're treating 18 and up, although we do have and will have, again, adolescent programming. We're in LA. We have levels of care ranging from IOP up through inpatient. And we're really excited to be here today. Don't hesitate to reach out if you want to hear more about Reasons, but we know you're not here today to hear about the program, so we're going to move on. Starting today, I want to start off by talking about language a little bit. I am a adult woman in a larger body, and I use the word fat to describe myself, and I may use that term to describe myself throughout this presentation. People may or may not be aware that there is. Don't say that. I don't like that. Do we have folks who aren't muted by any chance who can mute themselves?
Yeah, I took care of that. Sorry.
That's okay. So I will use that term. I think most people know that there is an effort to sort of reclaim that term as a neutral descriptor. I consider myself to be fat the same way I consider myself to be brunette. That in no way, shape, or form means that other folks need to use that word to describe themselves. I understand that it's a term that has been used in a derogatory manner for a number of years. I make the choice to use it in a neutral manner when I talk about myself, and we will talk a little bit about things like fat phobia and fear of weight gain and the thin ideal, and intertwine some of those ideas. And I did just want to acknowledge that I know it's a term that makes some folks uncomfortable. And I'm in no way endorsing that other folks need to embrace the use of that term about themselves or about others if they're not comfortable with it. And then the other thing we wanted to cover about language was use of the terms obese and overweight. Those are also two terms that if you're following kind of the culture of weight stigma and weight bias and fat phobia and eating disorder work, we really don't use those terms. They're very stigmatizing. What they're doing is they're medicalizing a body type, right? It's over what weight, over, is there a standard, is there a normal, right? And these are some of the questions we're going to unpack when we talk about weight bias. However, those terms are very common. They're used frequently. They're a kind of normalized part of language. And in particular, when we're talking about a clinical piece or sharing some research or relaying information from another source that uses those terms, sometimes those terms will come into the educational piece because we're quoting, we're sharing research, et cetera, and it is so widespread. So although we tend to not use the terms overweight or obese in our own conversation, if you do see that sprinkled in here in the context of some clinical information, that is why. And Claire, if there's anything else you want to add about that, let me know.
Yeah, I'm in full agreement with everything Fiona has said. I wanted to ask for some pre-forgiveness if I do use those terms. It is ingrained in the dietary programs that we all learn in. It's ingrained in how a lot of clinicians speak. So while I've been trying to weed it out of my language, I'm worried it's just going to slip out when I'm talking about this stuff. So I would like to apologize in advance if I use the term overweight, because I agree it's a useless term. It indicates that there's a perfect weight and that anybody over it is over it, which doesn't make any sense. A word about fat for me, I'm a little bit uncomfortable using it just because it has been so stigmatized. So while I'm trying to incorporate it into my language more, I think it's a personal decision. So I would never approach a person I didn't know and refer to them as fat, because that might feel to that person extremely derogatory. So so as I try to reclaim that word fat, I find myself pausing sometimes and feeling awkward about it. So that might come up too, even though I'm in full support of people taking back that word.
Thanks, Claire. So we're going to talk a little bit about dieting. We're going to talk about the food piece and some alternatives to dieting. And Claire's really going to dive into the nutrition piece and sort of dispel these nutrition myths that are out there. I think if you Google nutrition, you're going to kind of end up in that rabbit hole of diet culture really quickly. So our goal is to show you some alternatives to that. And then we're going to talk about the social cultural piece of being anti-diet. So we hope this fits the needs of everyone who's here today. All right, the dieting piece. So we're going to get started by talking about some numbers. Many of you have heard these, but if you have not, we'll start with the basics. 95% of diets fail. And that is when you look at long term. That's not necessarily in the short term, in that 3 months, 6 months, even a year. When you look past 1 year, and especially when you get to the 3 to 5 year mark, the majority of folks that have gone on diets have regained the weight that they lost and then some. We know this is yo-yo dieting. We know this is weight cycling. And unfortunately, we internalize this as failure or not being good at dieting or somehow not being disciplined enough or just not being worthy of releasing that supposed thin person that's hiding inside of us. And what really want to highlight when we talk about these statistics is that you are not a failure. There is not a thin person wanting to come free inside of you if you happen to be a person in a larger body. You are you. Your body is you. Body diversity is a beautiful thing. One thing I like to say to start these things off often is, and you can only see Claire and I from the shoulders up. You don't know what we look like beyond that. You don't know our bodies. You don't know our height. You don't know our gait when we walk or how we move through the space. But if you did, you'd see that we're very different people. And I like to start off with this example that if Claire St. John, my coworker, and I ate the exact same thing every day and engaged in the exact same amount of movement every day, do you think we would have the exact same body? Quick answer, no, we would not. Claire's significantly taller than I am to begin with. We have different shapes. The idea that there is sort of one body type and one body size that is universal is quite frankly just wrong. There always have been people of different body sizes, ranging from thin to fat. Again, I'll use that word because I'm comfortable with it. And there always will be. So when we talk about dieting and those statistics, it's really important to remember that. And I have this kind of big quote here about the amount of money that goes into the diet industry. And when we talk about the diet industry, we talk about memberships to organizations like Jenny Craig or Weight Watchers. We talk about books that are being sold. We talk about the folks that are ending up on talk shows and TVs promoting their new diets. We're talking about advertising. We're talking about the wellness phenomenon that has sort of overtaken the dieting industry. It's extraordinarily profitable, and it's built on a business model of failure. They depend on repeat customers. They are well aware that 95% of folks will regain that weight within 5 years and come back for more. As I put up here, this is deliberate and this is profitable. So we really just want to kind of ask people to hold that with them throughout this entire thing. And we'll talk about it more in the last section when we talk about the social cultural piece about that marketing. I think it's really important to share too the second statistic that's up here about how 35% of occasional dieters progress into pathological dieting or disordered eating, with as many as 25% developing a full-blown eating disorder. And really what we're talking about today is the fact that dieting is a risk factor for the development of an eating disorder. So when we talk about eating disorder prevention, being anti-diet is the most solid piece we have to move forward into eating disorder prevention. We can look at the genetic piece and try to determine risk factors in that way. There's some really interesting brain science happening out there. We can look at the trauma piece and the etiology of why people develop these maladaptive coping strategies to deal with what may or may not have happened to them at some point in their life. But we also know that that drive for thinness is a risk factor for the development of an eating disorder. And that's the one we have the most control over. That's the one where we, as a culture, as a society, and as individuals, can start to embrace an anti-diet perspective. If we can mitigate that risk factor, we're going to help prevent some folks from developing eating disorders. I think that's really important to know. The other pieces of this 5%, this mystery 5%, these unicorns that achieve long-term weight loss and maintain it, very often what they're engaging in is fairly disordered eating, to constantly fight what your body wants to be because of genetics, because of homeostasis. You're engaging in very rigid, very strict behaviors. And a lot of really interesting folks that I admire who talk quite a bit about weight stigma will say frequently, we prescribe for people in larger bodies what we treat for people in thin bodies. So behaviors that we would label as disordered or look at as criteria for, say, an anorexia nervosa or a bulimia nervosa diagnosis in a person who has lost a significant amount of weight and is in a thinner body is often what is indicated for weight loss in folks with larger bodies. So if we think about that conflict, I think it's important. The last piece is weight cycling, yo-yo dieting, right? This is the experience of most dieters. And the issues with weight cycling are huge. There's a lot of research that shows that some of the cardiovascular risk that's been attributed to being in a higher weight body is actually a result of weight cycling because of the additional stress of losing and gaining and losing and gaining on your blood pressure. It can impact your glucose levels, your insulin levels. It has a lot of physical impact that leads to poor health outcomes that have been correlated with being in a higher weight body. And often it's the yo-yoing that puts that stress on the body. Claire, you might want to jump in a little there to speak more to that.
Just to add, it affects the body's resting metabolic rate, right? So the body is going to fight any attempts at weight loss. I'm sure anybody who's been on a diet has experienced that. And one of the ways it does that is it burns fewer calories to compensate for the lost intake. So that can be a permanent effect. There's a study on The Biggest Loser, one season from 2016, a Harvard study that showed that people who lost about 100 pounds, their resting metabolic rate dropped by about 1,000 calories per day that they were no longer burning. So they all gained their weight back plus some. And that's yo-yo dieting. That's what we see over and over again. Another issue with that is weight loss early on tends to be muscle loss. So in yo-yo dieting, you tend to lose muscle. That's something you see show up on the scale as you're losing muscle. And when you gain the weight back, it tends to be fat. So it's changing body composition as well and making that more difficult as the years go on and as that cycle continues.
Great. Next slide. So I want to talk about weight stigma, and we're going to talk about weight stigma, which primarily impacts people in larger bodies. And then we're going to talk about internalized weight stigma, which really impacts everyone. And that distinction is important. Um, but we see anecdotes frequently about the dangers of weight stigma in healthcare. I think it was maybe about 2 or 3 years ago that a story circulated. It was really I was particularly moved by this one about a woman who had been in a larger body, who had repeatedly been seeking assistance from physicians because she'd been feeling short of breath, and she was continually being prescribed weight loss. No one was running tests, no one was really kind of taking her complaint seriously. They were dismissing her concerns about her body because of her shape and size. And this was a woman who knew her body, had been in this body for years, and knew something was different and knew something had changed. And long story short, essentially what happened was by the time she got any kind of medical workup and a diagnosis, she already had progressed to stage 4 lung cancer, and she passed. And she before she passed made a point of wanting to, and her family made a point of wanting to, noting in her obituary that it was bias in healthcare and a lack of attention to her symptoms that really led to this late diagnosis and unfortunate loss of life. And it's really heartbreaking. And what's even more heartbreaking is that there are stories like this that abound. As a person in a larger body, I can tell you that I have gone into the doctor to complain about a sore throat and had my weight mentioned. I'm asking for a throat culture, right? Strep's going around. What have I got? Can we talk about something else right now? There have been studies about uh, diseases like COVID, or when you look at one of the previous sort of epidemics that we dealt with in the last decade or so, the H1N1, one of those flu viruses that went around, that showed that, in fact, there did not appear to be a correlation between worse symptoms with folks in higher weight bodies. The reality was that people in higher weight bodies were not being offered the interventions by their doctors as quickly, medications, antivirals, anything like that, as quickly, or even tests as quickly as folks in thin bodies were. So they were allowed to get sicker before anything was noted, before a diagnosis was made, right? So it's pretty insidious the way we see weight bias impact healthcare, the way it can even eventually end up skewing certain data. And there's some evidence that shows, in fact, that some of these health disparities that have been correlated with being in a higher weight body can, in fact, be attributed to stigma and a lack of equitable care and healthcare for people in larger bodies rather than the actual size of the body itself. I'm going to talk a little bit about bariatric surgery as well. This is something that has been heavily promoted for decades now. And, what I find to be most ironic about bariatric surgery is that people in higher weight bodies struggle to find surgeons who will operate on them for a number of reasons. If you have a knee issue, perhaps you're trans or non-binary and you're seeking gender affirming surgery, right? There's lots of stories about folks looking for top surgery, for example, who are declined repeatedly by multiple surgeons because their BMI is over a certain amount. And yet it's supposedly safe to put these people under for weight loss surgery, right? The irony there is really challenging to understand for me, especially for me being in a larger body. You're going to tell me it's not safe to put me under to operate on my knee, which is causing me pain, but it is safe to put me under to amputate part of my stomach so that I can change my body shape for you. The irony there, I think, is challenging. And one of the other challenges with bariatric surgery is, I think, the lack of informed consent. We've seen a lot of sort of pop-up clinics come about that are just promoting this and not really educating folks about the potential side effects, right? We can talk about lifelong malnutrition because you're no longer able to absorb vitamins. I'm always going to defer to Claire when I start to talk about the nutrition piece because she's the dietitian. Um, it can be a real lifelong struggle for folks, the side effects from this surgery. So, while they may be going into it thinking they're having a positive impact on their health, we really just want to impress upon folks that informed consent about the risks of bariatric surgery, which can even be as extreme as death, or it's really important.
We've treated a number of people who have had bariatric surgery and either descended into an eating disorder or just need some guidance and help with how to get appropriate nutrition with their new stomach. I wanted to mention that weight stigma is also a big problem in the eating disorder treatment field. To get a diagnosis of anorexia nervosa, you have to be a certain body weight. You have to be below a certain body weight. So it misses people who maybe start out in a larger body and lose a dramatic amount of weight and have dramatic impacts on their health, but end up at a weight that's higher than expected. Those people get missed, right? They might go to the doctor, they might say, I'm having trouble eating. Sometimes they get accolades for it, like, wow, it looks like you lost a tremendous amount of weight, great job. They rarely get asked how they lost that weight or how quickly. It's just not on a lot of people's radars. And I feel like this happens in eating disorder treatment centers too, which breaks my heart to say, because that's just the worst, to have people say when they come into treatment, like, well, you don't look like you have an eating disorder, what's going on? It needs to be more recognized as part of, as a problem, and it's not.
Mm-hmm. And so these last couple points up here is, we've started to see more weight stigma research really talk about how weight stigma and weight bias seems to be one of the last sort of okay forms of discrimination, right? That it's still acceptable to make comments about people's bodies that, most people, if you ask them, is it okay to comment on someone's race or gender or sexual orientation, would answer no, of course not, but think that it's just fine to make judgments about people in higher weight bodies. So we are seeing a lot of the literature starting to say, look, this is a social justice issue. This is a discrimination issue. This causes a lot of shame, anxiety, depression. It's not okay to treat people like this, but they're still framing it as, and guess what? It doesn't help people lose weight to shame them. It doesn't help prevent obesity to stigmatize people in higher weight bodies. And that's a piece that I would like to see go away, because that is still sort of setting this goal of eliminating fat people from society, right? And as a fat woman, I don't want to see that happen. We're here, we always have been, we always will be. So the idea that weight stigma is wrong because it doesn't help me lose weight doesn't quite hit the mark for me. So I just want to share that and have people think about that. But we obviously know the risks of bullying. We see what happens with bullying, in particular with adolescents, but we even see it among adults. We know the rates of suicide that are associated with bullying. We know that weight and shape is something that is a target for bullies quite frequently, especially among adolescents and young people. And we see public health messaging still really inundating us with this idea that large bodies are a problem that need to be fixed. And if we can sort of impress upon you as we go through this to constantly be thinking about these things in the way that this has all been framed and set us up to think this way, then we can start to kind of unpack it and reject it as a group.
So just to touch back real quick on our title, How to Be Anti-Diet, this is part of it, right? If somebody is like, oh, I need to go on a diet, just say, why? And kind of maybe having a discussion about all of these things.
So going back to this idea that weight bias is harmful to people of all shapes and sizes, I want to talk a little bit about internalized weight stigma. And internalized weight stigma is when you hold on to this belief that these negative stereotypes about weight are true, and you apply those to yourself, right? So if you believe that people in larger bodies are lazy, that they're gluttonous, that they're not healthy, and if you believe those things and apply them to yourself, that's internalized weight stigma. And that belief can be held and turned on yourself regardless of your body shape or size. And what this comes back to is that risk factor for the development of eating disorders, right? And that's what we're talking about. We're talking about not just treating people equitably and fairly, we're talking about preventing eating disorders. And what tools do we have where we can prevent more people from developing these deadly illnesses? If you fear getting fat, if you internalize these beliefs that being in a larger body means that you're lazy, means that you're unhealthy, means that you're gluttonous, means that you're out of control, you are more inclined to do harm to yourself to avoid that. And that's why we talk about weight stigma and weight bias when it's internalized being a societal problem, right? People are developing eating disorders in part because we know it's a perfect storm. We know there's a lot of different things that contribute, but in part for a lot of eating disorder diagnoses, because of this overvaluing of thinness, and the social cultural piece that supports that is what we're trying to deconstruct today. So going back to the how-to and some tips, and we're going to sprinkle these throughout. So we'll just start with a few quick ones. Decreasing body talk. I say decrease with the goal of eliminating it entirely. It's so ingrained in us to say, "Hey, how are you? You look great. Have you lost weight?" Right? And those of us who are in recovery from eating disorders, those of us who work with folks with eating disorders, those of us who have loved ones with eating disorders, we've learned that that's not an okay thing to say, but it's still very, very normalized. And even if it's not the sort of very blatant, oh, have you lost weight or have you gained weight, which some family members and friends don't seem to shy away from pointing out at times. There's so much other body talk that comes along with, how do I look in this? How do I look in this bathing suit? I don't know if I should wear that. I think everyone's probably seen the "what is a bikini body" meme, where it's just like, do you have a body? Put a bikini on it. It's a bikini body, right? We're so ingrained with body talk. You look so beautiful today. Even when we're paying each other compliments and someone saying, I hear a lot of you look so thin in that, you should wear it. Yeah, exactly. Right. I grew up thinking I couldn't wear horizontal stripes for some strange reason. And I love stripes. They make me feel like, stripes and red lipstick make me feel like I'm in Paris. Right. So don't tell me I can't wear horizontal stripes. Thank you for bringing that up in the chat. So I love this little kind of graphic that we added here of things to say to folks when you want to compliment them, because it can be really hard to think about non-body related compliments. They're so ingrained. You light up the room. I love hearing from you. I feel lucky to have you in my life. You inspire me. You mean so much to me. I love commenting on things like the way someone laughs, right? Oh, I love hearing your laugh if you've shared a joke or something. I love the positive perspective you always bring to things, or even alternately, like, I love how snarky you can be sometimes and how cynical you are, right? There's so many other things we can compliment our friends and family on that aren't body related. So starting to explore that and practice that is a really nice tip for changing the sort of frame of diet talk and body talk. Redirecting the conversation as well. And when I say to disclose or not to disclose, do you want to disclose that you are in recovery from an eating disorder if you are, or that your family member is in recovery from an eating disorder? That's a very personal decision. You might not want to. I can also tell you it's a really effective way to shut down the conversation. If you're surrounded by people who will not stop talking about their most recent Weight Watchers meeting, sometimes just saying like, look, hey, my sister's in recovery from an eating disorder. I've worked really hard to eliminate this type of topics from my conversation. Can we move on? We'll quiet everyone in the room. Much in the same way that if someone says they don't drink, they're often going to be peppered with a lot of questions. But if they disclose that they're sober, often that will kind of stop things. So that's something to consider. I've used that when I've worked with personal trainers. Anyone who's worked with a personal trainer knows that they're all pretty much coached to start to talk to you about weight loss and offer to measure your body fat and this and that. So typically right off the bat, because I love to exercise, I love to lift weights is my thing. Right off the bat, I say, hey, I've worked for years with folks with eating disorders. So weight loss is not A, my goal, or B, something I want to talk about really. My goals are better energy, regular exercise, gaining strength, and whatever else they might be at the time. And in general, I've had trainers just say, wow, that's really refreshing. Good to know. But I set that firm boundary like, this is what I do for a living, so that's not going to fly. And it just takes it off the table. Um, some tips about self-advocacy with medical professionals as well. This is a tough one, but if you're in a higher weight body, you've probably been faced with this. You go in because you sprained your ankle and someone talks to you about your weight, right? You go in complaining about symptoms and the doctor just suggests weight loss. And a couple of things I would suggest. One is you can always ask a medical professional, what advice or what tests would you recommend for someone in a thin body if they were presenting with these same symptoms? And I would like, the I would like you to afford me the respect to offer me those same treatments and that same advice, that same testing. Um, there you go. I was told by a doctor everything is normal except your weight. Right. Did this doctor run tests for you though? It's just right off the bat. They're like, that's it. That's the first thing. So really asking that and putting it that way, well, what would you be telling me if my body size were different? What would you be recommending? And can we do that? The other thing is if they're still rejecting the idea of running tests or other sort of diagnostic tools for you, making a note, asking them to make a note on your chart that you requested that and they declined. And that will often move them along because you deserve equitable care. There's some great resources out there as well. And if someone is looking for more resources about little like things you can bring into a doctor's office to present so that you don't have to exhaust yourself explaining it every single time, kind of like a weight advocacy card in a medical setting. There's a lot of great activists out there who have come up with some stuff. So we'd be happy to connect offline and share them.
Something else I would recommend is to call the doctor on his claim. If he says you need to lose weight, ask why. If he says, he or she, says, you could have high blood pressure, you could have high cholesterol, say, oh my gosh, that sounds bad. Can I get tested for it? A lot of times doctors will prescribe medications just based on body size, and that is inappropriate. I know people who started taking blood pressure medicine and they started fainting because they absolutely did not need that. It was the wrong medication and it was based on their physical presentation. I wanted to say about challenging diet talk and weight stigma. I started my career in dietetics in eating disorders and it was a brand new field for me. I knew nothing about it. And going to the inpatient unit and being in this culture where we don't refer to bodies amongst staff, amongst patients, we do practice that. Like, you look really happy today. What's going on? Instead of, anything about the physical appearance. It's a relief. It's such a nice environment to be in. So it's worth practicing that and seeing how that improves your relationships with your friends and families, no matter their body types, no matter their background with eating disorders. It's just a much nicer way to be, and it really sees the whole person. We are so body focused. It's when you start to notice it, it's kind of amazing. Like, I would be riding the train and somebody behind me would be recounting to somebody sitting next to him his entire day of eating. Like, he was on a diet and he was telling this man exactly what he ate every hour of the day. And it was really shocking to me. Like, wow, that man must be really hungry right now.
Yeah.
Moving away from that is such a relief.
Yeah, it is nice when you can cultivate that environment. And it does spread. I think most of my friends and family now know not to kind of talk about that stuff around me, and it's great. Okay, next slide.
Okay, so now it's my turn.